Thank you. Well, I'm going to use 30 seconds to thank Rebecca and Kathy and Carolyn for helping organize this entire thing, taking care of us so well. Stand up and take a bow. And also to thank Dan Diaz for starting us out with such a vivid picture of Brittany, his wife. There's many things I could talk about from our session. I want to start by, I thought Dan Slomasi did a really wonderful job summarizing a series of concerning things, potentially, about the research. And one of them is, how do our beliefs potentially affect science, but more importantly, even affect the questions we're asking? And I was really thinking about that when, so many of the people who are actually seeing these patients said that they would never bring it up with a patient. So that's an example of something that really we have not dug into at all to understand that at all. But the bigger theme that I am hearing is that even, I'm a psychiatrist, most of my work is understanding individual patients and their motivations and their competence and their mental disorders, but that there's a possibility that even if we could all be assured about the patients themselves, that the potential for acceptance of this practice increases distrust in marginalized groups is something that I don't have the research skills to address. That I think that work would need to come out of sociology, but I think it's really important that we begin to look at it. The other thing that he brought up is that the importance of really the ethical concerns cannot, and the scientific concerns may be on parallel tracks. They don't always intersect, but the importance of keeping ethical ideas in mind all the time when we're looking at these issues. In the United States, we have misused science, we have misused policy. We look back and we've made mistakes, and that we need to keep some skepticism about many of the things we're doing, particularly these days. So thank you, Dan, for reminding us of those. I'm not covering everything you covered, just some of those issues. With regard to decision-making capacity, this is an area I've been particularly interested in, and I'm going to come back to it a couple times. That when the law was implemented in Oregon, Kaiser Permanente, one of our largest systems, hired me to do psychiatric consultations on every single patient who requested aid in dying. Now, interestingly, I never saw a single patient that I thought depression was impacting the decision enough to disqualify them. But what didn't come up is that I actually saw 3 patients in which I was concerned about voluntariness. And in one way, I think, these patients are so determined, and it's really hard to take this medication unless you really want to. But there are some situations in which that came up. For example, one was a husband and wife who had been married for 50 years, both terminally ill, wanted to take it together. And one of them was so much more dominant than the other, it seemed like, in the relationship. So that was a lot of work to sort that one out. And the other 2 were cases in which there was both mental disorder and potential voluntariness issues, and one of them got excluded. So let's not forget that. I was also reminded from Dr. Kim that we have a lot of work on decision-making capacity and methods for that could be applied to look at agreement among mental health professionals. Do they bring similar standards? Those kinds of things that could be helpful. I thought Tony Bach brought some very interesting ideas that I've also been thinking about, is that the patients that I've seen who's made these requests and carried through, many of them are larger than life. They're quite remarkable. And what they bring is also these kind of signature deaths. They have big parties, and they things that we didn't really used to think about, that, and now that's all kind of going into the mainstream. And as things change, I think we need to keep track about, there's a group of people who are on the leading edge of changing our ideas about death and how we're going to die. And we can't
I'm tired of it all, in fact, by myself.
Okay, sure.
Sorry. And that we need to keep track of it. It's coming into the mainstream, and we do need to keep observing it. Finally, I wanted to talk a little bit about, go back to my Kaiser experience, because I do also think there's a real importance of research, because otherwise what we're getting about information is from the blogosphere. For example, one of the cases that was brought up was the case of Kate Chaney. Now, I have permission from her family to talk about that case, because I was the psychiatrist who originally disqualified her. And what actually happened was quite different than is often been presented. One of my agreements with Kaiser was that I would see all these patients in their home, a way of really getting a better understanding of patients. Now, that was a mistake, and I'll tell you why. When I saw Kate Chaney, she had gastric cancer. She'd just come out of the hospital for a GI bleed. She was really pumped full of medications, and she had mild delirium. And when I saw her, she couldn't really tell me her alternative. She really couldn't tell me what hospice was. She didn't do well on cognitive exam. And I said what I usually say when a delirious patient can't tell me things is, let's wait for the delirium clear and let's reevaluate her. But in addition, her daughter was a force of nature. Her daughter had been born deaf, was a member of the deaf community, and was very suspicious of doctors, very suspicious of me, and felt that her job had been an advocate in her community, and her job was to advocate for her mother. And I was then concerned about coercion as that happened, because when I'm in the house, the daughter keeps coming into the room to answer the questions. So my response is, we need to do another evaluation, because the daughter needs to be separated. Kate Chaney needs to recover a little bit, but that was presented as doctor shopping. So I helped find another person to evaluate her. I thought it should be independent, and then she was after she recovered from her delirium. And then there was a couple of other evaluations from the ethicist and head of the ethics group at Kaiser, who was also a pulmonologist. And she was found to be competent, and all the concerns were about coercion went away. But here's the other thing about Kate Chaney that really comes up is, we talk about the control, but where does that come from? So Kate Chaney had escaped from Nazi Germany. She had spent time in camps. We hear about this concern about as people want control so they don't become disabled. But what I hear more often is people have had life experiences where other people have controlled them. And they decide, I will never be controlled again. It is what they're proudest of themselves about. It's what other people admire about them, is that attitude. And many of those experiences happen when they're young. It is a very adaptive response in some ways, and many of them have been very successful in life. So there's a tendency to dismiss that need for control, but it is very important to them. And I think we can look at all kinds of interventions in end-of-life care, but it really is hard to leave this world in control. That needs more looking at also. Thank you.